Welcome. Good evening. My name is Tony Clark of the My Brother's Keeper Task Force. Excited to be here this evening to discuss medical racism. This evening, we put together a consortium of a number of brilliant minds who are going to help us think about this very important conversation, not just only locally, but nationally. As I've stated before in previous conversations, in no shape or form am I an expert. I am just as curious as everyone who's listening to this conversation today and those who will listen to it on its replay, both on 22 City View and on YouTube. We're going to watch a brief video, and then we're going to meet our panelists.
The canon that identifies as medical ethics actually tracks back to the 5th century and the medical studies of Hippocrates and the familiar promise found in the Hippocratic Oath. First, do no harm. History, in both the oral and written tradition, have long documented the dehumanization and devaluing of Black and brown bodies under the guise of medical and scientific breakthrough. While the Tuskegee syphilis study, where African American men were fraudulently enrolled in and then not treated in a medical study, is the most widely discussed, it's really just another sad placeholder in a long line of medical and ethical violations visited on minority communities. There's Dr. James Marion Sims, the father of modern gynecology, whose celebrated breakthroughs came at the expense of Black women who were forced to undergo medical procedures without anesthesia because he believed that Black people didn't feel pain in the same way as whites. And then there's the story of Henrietta Lacks.
In 1951, Henrietta Lacks came to Johns Hopkins Hospital with cervical cancer. While there, doctors removed some of her tumor cells and discovered they could thrive in a lab. It was something human cells had never done before.
This biopsy taken from Henrietta Lacks produced a cell line that would grow essentially forever and was immediately distributed all over the world.
Named HeLa cells after Lacks, they were used by Jonas Salk to discover the polio vaccine. They also aided research in cancer, AIDS, and diabetes. Dr. Francis Collins, director of the National Institutes of Health, says they've saved millions of lives.
This is everywhere.
But Lacks, poor and uneducated, died in the hospital, and the scientists took the cells without her consent.
Tonight, under the glare of a global pandemic, we're once again faced with balancing questions of health, trust, government, and history.
Thank you. Before I begin, I just want to thank Calvin Lindsay, Danielle Jones, and Ty Belletti, who I work with in this work with 22 City View, as we are so excited about bringing this really important conversation. And I'm actually really excited to see our friend, Dr. Wayne Altman. When we launched My Brother's Keeper about a year ago, a little under a year ago, we were on the prefaces of looking at race, access, and equity in a number of ways. And in those conversations, we met numerous folks who were both in the medical fields, civil and social justice spaces, but also individuals just want to do really good work. And Dr. Altman was one of those folks who asked us, why not be big and brave in this moment? So while you didn't expect this, I want to just thank you for kind of pushing us a little bit. And these conversations are not only about tonight, but we're hopeful that these conversations will continue to pick up. And I think that you're one of the folks who helped push Ty and myself and our team, many of whom are on here, from Frank Barnes to Nico Emack to Elijah Booker, to think big and to push not only our city, but our country to not only discuss race, but to make it a part of the lexicon on an everyday way. And so before I begin, I want to let you guys just go around, introduce yourselves, talk a little bit about your work, and I'm going to get into a couple of questions, some of which I may ask each person, some of which I'm going to kind of just jump around, but all with the intention to hopefully grow our community to be more curious about this really important issue. I want to state that we may have some other folks coming in. Obviously, when you're dealing with folks in the medical field, they have tough schedules, and they're going to help us have this conversation not only today but moving forward. So just give us some time and some space as new voices may be coming in throughout the course of this conversation. So Joanne, we're going to start with you. If you can take about 60 seconds to tell us a little bit who you are, what you do, and why you're here this evening.
Sure, absolutely. Thank you, Tony. So my name is Joanne Bell. I am the Director of Business Operations for a Black-owned mental health clinic by the name of Randolph Behavioral Health Services, and we are located in Stoughton, Mass. And so my job primarily is to get the word out that, number one, our clinic is open and that we have a diverse staff and we have multiple languages that we represent at our mental health clinic. Languages such as Spanish, French, Haitian Creole, Mandarin, Montserrat, Patois. So we've got a plethora of different clinicians that can actually service those that are in the community, not just in the Stoughton area, but anywhere in Massachusetts. And so I'm just excited to be here, to be able to weigh in on this conversation with this wonderful panel of great minds. Thank you.
Thank you. Dr. Altman?
Good evening, everyone. It's a pleasure to be here. Joanne, that sounds amazing. I can't wait to learn more about that. Mental health care is such a need for everyone. And it was a need before the pandemic. And now, my goodness, it's another pandemic that we have. And so the work that you're doing and that your company is doing is filling such a great need. I'm really delighted to be here as part of this panel and part of this group and part of this conversation, really. I'm the chair of the Department of Family Medicine at Tufts Medical School. I'm also the co-owner of a family medicine practice in Arlington, just next to Cambridge. And I have been thinking a lot about the vaccination rollout and kind of wondering how that would go after close to a year of watching a pandemic that showed us something that we already knew, that healthcare inequities were alive and well in the United States of America. And it would shock none of us to know if we went a year back and I said to you, I predict that COVID-19 is going to be way worse for Black people, I'm pretty sure most of us on this panel would say, yeah, of course. That's not going to surprise anyone. And it told us something that we already knew, but it really reminded us in the worst possible way of how urgent this work is. So delighted to be here to kind of brainstorm how we can do that work together.
Awesome. Thank you. Leandra? I'm sorry. You're on mute.
Hello again, everyone. Now that I've taken myself off mute, I'll start again. Yeah. So I am Leandria Brantle. I am the co-founder and current Chief Operation Officer of Victory Human Services. Victory Human Services is located, our main office is in Brockton, but we started in Boston. We serve almost 600 families at this point, individuals and their families. And what we do is we work with adults with developmental disabilities, and we work with several hundred seniors who are at risk for multiple things in our community. Most of the folks we serve are from communities of color, poor, and just have multiple issues going on. So I am so happy to join this panel because, as you know, it is disproportionately affecting these folks that I'm talking about. And over this past year, our team has gone above and beyond dealing with food insecurity, with anxiety from clients and our staff around this whole pandemic, and with the social justice issues that are going on. So this has been a very, very tumultuous year. And now we're running into how do we make sure that our folks continue to get the level of care that they need in this kind of condensed, intense environment. So thank you. I'm looking forward to this conversation.
Thank you for being here. Thank you for joining us. Dr. Jean Baptiste? Let's get you off mute as well.
Yeah, we are.
Thank you for inviting me. I'm Marie-Jean Baptiste. I am an attending physician working at Cambridge Health Alliance. I'm a primary care doc, and I also an HIV primary care specialist. On my free time, I do community education / outreach. My husband and I, we have a small nonprofit organization where we do media. We do outreach to the Haitian community on the media to educate them about their health. Cambridge Hospital is a cultural, multidisciplinary place where we take care of a lot of immigrants from diverse walks of life. And I also forget to say I'm medical director for healthcare for the homeless, the Cambridge side. So we've been heavily hit by COVID. It's been very painful because I lost so many patients. So many people have been very sick. Some have not recovered. Some are still in rehab. So it's been a very sobering experience. I'm delighted to be here with you guys.
Thank you for being here. I'm going to ask a series of questions, some of which, as I mentioned earlier, I'll ask all the panelists, and some of which will just target individual panelists. And so I'm going to ask a question to everybody. I want folks to maybe take 90 seconds. And I'm going to start with you, Joanne. What does racial bias in healthcare look like?
Wow, you gotta give me the hard one first, huh, Tony? All right. So racial bias in healthcare, in all honesty, just the fact that we have to put those two words together is already stirring up in my spirit. But more importantly, what does it look like in healthcare? I believe it starts with the color of your skin. One of the anomalies that takes place is that I'm a walking contradiction in that when I'm on the phone, prior to going to a doctor's appointment or any appointment for that matter, presumably they think they're talking to someone that is actually Caucasian or white. I've had this happen to me several times. And then when I show up, whether it's at the appointment or at whatever positioning, and they're looking for Joanne Bell, they look around me, they're looking around. And then all of a sudden, when they notice that it's me and they're in shock, oh, wow, Joanne Bell. And that kind of response in itself in that environment, oftentimes because I've experienced it, understanding it happening in healthcare, it's real. And so that racial bias, I think my name, because of the fact, again, it's deceiving, it doesn't come across as being you can't necessarily attach a race to it till they see the skin color, but then that question starts to come in. So to me, when I hear racial bias in healthcare, what I'm really hearing is that that person is taking an opportunity to immediately make a choice or make a decision based on a name spelling, even an accent or what have you. And then immediately that care is represented in the same way. And so I think that within healthcare, it's sad to say that there is racial bias. And I believe that we definitely need to do something. Even in this conversation tonight, it's going to be great to really hear from all the other panelists. But I think more importantly, what are we going to do about that? How do we impact or affect change? And I think it starts within us. We have to first understand that sometimes we're going to have to help educate people to get to know us before you judge us. And I think that in itself, it's two-pronged. It's the person coming in knowing that it's okay that someone may look at you differently until they get to know you. But then also, if they don't get to know you, you yourself have to speak up and empower yourself so that you don't become a victim of that bias. And so I think that even though I know this is going a little deeper, but I would say that I think it's important not only to have that discussion, but to help people understand that they do exist. And then how do you learn to be able to adapt in that type of environment?
Thank you. Dr. Baptiste, you had mentioned a number of things that are very important for the region, but as a kid from Cambridge specifically, I don't want to say area 4, I'm from the port. So as a kid from the port, we have I grew up with a large Haitian community, and oftentimes, quite frankly, just to be frank, we created a space, and I say we as a community, we didn't welcome open arms our Haitian brothers and sisters. And you had mentioned your work, particularly as it relates to supporting the Haitian community, and also homeless communities. They're not analogous. I'm just mentioning both of the things in which you referenced. But I'm curious, keeping in mind the same question around racial bias, how do we support not only racial, how do you see racial bias in the healthcare system? What does it look like? But how does it also look like for our Haitian brothers and sisters?
Okay. When you say racial bias, I see stereotype. I see it's unconscious. So you're not aware that you're doing it, but you're doing it. And I have to tell you that my first encounter with medical medicine in the US is like when I was shocked to see that they were categorizing people by race. And the fact that you are from such a race, you assume you have such a disease. Yes, there is genetic, but sometimes we make grave mistake that sometimes you go beyond repair. I'm going to give you the case of Haitian HIV. You may be too young to know about that. But like when COVID just appeared, we didn't know what it was. The same thing was for HIV disease. So they start by category. So they had different category of people, but Haiti was the only country that they consider as a risk factor. And that creates so much mistrust in the community, so much disengagement from the community, and so much anger. People lost their job, the children could not go to school, and the one who had HIV were scared to say that they have HIV disease because they know they will be ostracized. This is why I'm an HIV primary care provider.
Thank you. So Dr. Altman, part of your work is working, kind of teaching up the next generation. And keeping that in mind, how do you prepare that next generation to look at racial bias in the healthcare system?
So it's a great question, Tony. And, you know, the media is so powerful, and the images that we see in the media and social media, every single one of us has bias. And you're taught as a kid, you can't judge a book by its cover, and yet everybody does, and still does. But the difference is, if you can be aware that you have that propensity, and if you are aware of what biases you have, and Dr. Jean-Baptiste was talking about how it's unconscious. If you can change it from unconscious to conscious and be aware of it, because presumably you don't want it. You don't want to negatively judge somebody in an irrational way that doesn't make sense, that isn't fair to that person. And if you're conscious of it, you can kind of try and curb that. And so we have a session for the medical students specifically around implicit bias and exploring that and what happens and how to be aware of it, what to do with it. And to also, we in the same session, we talk about microaggressions and how to recognize them in yourself and others, and how to speak up and what to say and how to say it. These are all really important things. The other thing I want to mention here is, Tony, is that the most important thing that we could talk about with regard to bias is systems, because the most potent way to inflict racism is systemically. Yeah. And boy, are we good at it. We have a lot of different systems that are very potent at inflicting racism. And I think we've had a little bit of a reckoning in the last year where people who were not really thinking that racism was a very big deal, which is really easy to think when you're white, by the way. And there are a lot of people thinking, what's the big deal? People are playing the race card and that kind of thing, are starting to realize maybe this is a big deal. And I think a lot of people knew it was a big deal, but there are a lot of people who didn't, who are now starting to come around to that. Better late than never, I guess.
Right.
And it gives us an opportunity to really look at the systems of big institutions that we're a part. For example, when the pandemic hit in March and the governor said, okay, new system, every doctor can use telehealth so that patients can get on their laptops and use video visits with their doctors, problem solved for access. Not realizing, there's some people who don't have access to laptops and video technology. And so that's systemic racism.
Right. Leandra, I think that I want to just kind of take a step back, because the work in which, having had the opportunity to meet you and talk with you, I think your work is its scope is so broad in that it's touching so many folks throughout the Commonwealth. And I think that in terms of when you're dealing with the populations in which you're serving, those folks are dealing with, obviously, the internal an implicit bias that goes on just because of what Dr. Altman said, systemic racism and structures that have both political and also in terms of societal. When you think about the people that you serve, how do you prepare them to deal with the world in which they're going to deal with implicit bias?
So one of the things, Tony, that's an awesome question, and we are still in process. And so, you're always going to get the 100% true answer here. One of the things that we've done is we have written for a grant, and we got a grant, and we're going to be supplying several hundred of our families with tablets to allow them to access their doctors, because as Dr. Altman said, there's an assumption that everybody had a laptop, or they have a smartphone, or and our folks do not. So we're buying, I think, either 250 or 300 of those tablets. But along with that, we are getting them a year of Wi-Fi access. There's an assumption also that every person automatically has a hotspot or has Wi-Fi, and they don't. Another problem that we're having with our staff, that many of our staff are immigrants from other parts of the world. And so they are very deferential to doctors and to nurses and to people who are well educated. And so what we find is it can be very hard for them to kind of push back and ask questions and go against what this expert has told them they should do. So there's this level of we're not supposed to push back. So what we're doing is we're going to be standing up a medical advocacy training that all of our staff, no matter what position within the agency, are going to have to go through. We want them to be able to speak up for not just the clients they serve, but for themselves. And this has been an ongoing challenge. So we do have systems and all kinds of things in place, but at the end of the day, they've got to be willing to kind of push the boundaries. In some cases, when things are difficult, if someone is really not getting the service, then our senior leadership team will get involved. We will make calls. We will write letters. And so at my level, when we start, dealing with the higher level, things start to kind of loosen up and move a little faster. But we hope to have a little mini army of victory advocates that can really go out and protect the needs of the clients that we serve.
Right. Thank you. So there are a number of questions I have that I would love to kind of throw out there, but I also want to be conscientious of the fact that in about 30 minutes, we want to open this up to the folks, who are on the line to ask questions of each of you. And so I have about 6 or 7 questions, one of which I'm going to kind of go off script a little bit because I've heard the backgrounds. And so I want to ask a question that really has to relate to, Black women. And particularly, we have non-Hispanic and Black women are more than 3 times more likely to have maternal death than white women in the US. How do we look to reduce this maternal morbidity rate for Black women? And so I'm going to start with you, Dr. Baptiste. What do we do about this real reality that in terms of Black women, quite frankly, are dying during labor at 3 times a higher rate than their white counterparts?
Well, one of the issues is access to healthcare. A lot of people are working 2 jobs and they don't have, there is many reasons why people don't have access to healthcare. It could be that they are too busy taking care of the family, so they don't have time for themselves. They don't have health insurance. They don't know how to access health insurance. And they have chronic illnesses which are never addressed. And so all of those put together, and there is a fair amount of undocumented people who do not qualify for health insurance. And recently, it's been even more scary because even though some places we have what we call safety net healthcare, but because of the label and what happened recently in the government, people are afraid to seek for healthcare. So they come very late. And because they are very late, then they have tendency to die. And sometimes also you may do the diagnostic, but it's delayed because of transportation, because of communication. So it takes, and illiteracy is another part, to educate that person about their issue and how important it is for follow-up. So all of those together make it like a mixed ball, multiple cause for the increased mortality that we see. Women are dying for cervical cancer, for advanced breast cancer, and a lot of stuff that could be prevented. Even for HIV, people, immigrant or women in general, tend to be diagnosed very late compared to the rest of the population.
You know, Joanne, Dr. Baptiste had said something, left to die. And I want to be conscientious of the fact that in terms of throughout the course of the summer and even now, we often, even when we think about George Floyd, we don't yell or scream the name in the same urgency of Breonna Taylor, right? And so what we see throughout the course of this country, particularly as it relates to social justice movements, we see folks who have cameras who are showing, unfortunately, state-sanctioned executions of Black males, right? Mm-hmm. And there's an uproar, and and we get all, and we get, myself included, we figure out we have to organize, we have to, put together, institutions and infrastructures to move on this, on these unjust ills. Why don't we do the same when we think about the rates that Black women are dying at with respect to birth?
Well, in part, I believe that part of that has to do with how Black women are perceived. We are the minority within the minority. We're that last leg where we're not looked upon and we're not given that respect. We're not given that airplay. And it's all lives matter, right? So when we think about it, especially being a Black woman, was it very disconcerting to see Breonna Taylor and the way she was treated? Absolute. But at the end of it all, I believe that just as Black women have to understand that because there's so much that's coming against us in so many different ways, and we have to deal with all of those doubles, whether it's if you're a single parent and you're balancing house and home and you're trying to take care of everything and you're taking care of yourself last. I think Dr. Baptiste was spot on when she was talking about the different things that women are dealing with. And it's not just women, but in particular, when you think of women and what they go through and how it's not necessarily, especially for Black women, that's not something that's part of that everyday conversation. When I look at some of the clients that we have, that's what we call our patients coming through the door with the various presenting symptoms that they're coming in. The high incidence of what I'm seeing is depression. It's coming in strong. So you're having people dealing with these mental health issues that are also debilitating and crushing them. So we're thinking about the physical health, but the mental health also plays a role in what's happening physically. So if someone's going through, if there's any food insecurities like Leandria was talking about a little while ago, if there's anything that's going on, the stressors that are common, I believe, that are also impacting the Black race, but in particular Black women, the stressors that they have to go through to try to fit in, to try to assimilate. There's other things going on that are adding to why you're seeing that mortality rate increase. And the education, that psychoeducation that women need to know about their bodies, oftentimes they don't talk about it. If we take it to just the conversation about breast cancer and proper breast health, you know, if you speak to a Black woman, in which I have, and had conversations with different Black women about how do you take care of your breasts, that's not something you hear in conversation. You're not hearing, hey, how you doing? How's your breast doing? We're not checking in like that. But believe it or not, when she was talking about the high incidence of the late diagnoses in breast cancer, especially in a lot of Black women, it's because of the fact that these conversations don't take place in our communities regularly. So it depends who you're talking to. I see your finger going.
No. I want to say something. You were saying,
yes.
Okay, don't pay attention to me. I'm just. You mentioned something about, particularly as you're talking, I hear health disparities, right? In terms of
Yes.
health disparities. So I want to stop for a second. I
Okay.
want to watch a quick video. I want to come back to you to finish that thought about health disparities, and we're going to go to Leandra. So we're going to watch a quick video.
Will do.
It's hard for me to understand how we got to a place as a Black people that we turn our nose up or frown upon therapy. And I think we're the people that need it the most. When you're a man and you're a slave and you have to watch a slave owner do what they do to your daughter or your wife, or your families are separated and sold to this plantation and that plantation, and you beat a person down in their mind because truthfully, you know, we outnumbered them. So if you didn't whoop us in the mind, you weren't gonna whoop us physically. So they learned, if we got you in the mind, we got you. And I don't think that thing is, we're far removed from that.
And I just asked for that video to be queued up because as you were talking, I thought a lot about just in terms of those disparities in the mind, right? In terms of kind of that psyche. I'm not going to get too caught up in myself, but you know, one of the things that I did for myself to take care of myself was to get therapy, right? And I'm in a space now where one could say I don't need it, but it's a part of my routine. The same way I get on my bike and I run, I have to have it, right? You know, it kind of got to kind of keeps me going in a lot of ways. And so, can you just finish your last comment? Because I have your last point that you were making, and you can point to the video as well, Joanne. But I want to ask Leandra a question as well about this issue.
Sure, will do. So kind of the vein where I was going at is these common stressors that we see, these are the ailments in which they impact a person's mental health. Mental health is mental wealth. That's what I say. And the mental, if the way you're thinking, because of what's going on, those stressors are impacting you, it's going to respond in your body. A hairdresser can tell you're under stress by just washing your hair and dealing with your scalp. I'm talking to Black women here. Well, when we get our hair done, your hairdresser can diagnose you quickly and say, why are you stressing? Because she sees that your hair is balding in the middle. But some women don't take that into account to realize I got to check on me. And so one little note that I took off the video as I was listening, I got from that Black women, we're supposed to be strong. Anytime that we get sick or something's hurting us, the presumption is we're not supposed to show any signs of weakness. And so illness at times can be weakness. Sickness can be perceived like that. There's nothing wrong with me. I'm okay. And so we have to check on our brothers and sisters to check in, are we okay? So I'm going to scale back because I don't want to take in too much time, Tony, but I appreciate that question. I think it was very poignant.
Yeah, so thank you for the response. It was thorough. Now, as you were talking, Leandra, I thought about this as Joanne was speaking and kind of thinking about everything we're talking about. And I'm going to go a number of different places today. Don't blame it on my head, blame it on my heart, because sometimes folks will just throw me places that I will go to. But I'm thinking about the work in which we do, right? All of us do in our own spaces. How do we create a culture where we normalize the importance of taking care of our brains? And if so, how do we do that? Do we employ the schools? Do we employ the youth centers? Do we, re-engage the church, right? How do we do that? Just throw it out there.
Well,
questions on you.
Go ahead, Leandria.
I just wanted to say what we did in my organization over the last year. We are using EAP, and we had it probably about 10 years ago, but we deliberately put that in place because of the amount of stress and strain that our staff was experiencing over this last year. And so if you were to come to one of our senior leadership meetings, we have tried to take the stigma away from saying that you need therapy. Like, it's every day. Like, you get up, hey, I got to talk to my mentor. I got to talk to my therapist. We have to take the stigma away from needing someone to talk to debrief with, to share our feelings with, and be very open about that at the senior level. And so that trickles down, really saying that it's okay. It doesn't mean that you're weak. It doesn't mean you're going to get fired. It doesn't mean that you are crazy. So in our communities, particularly for women, there's this notion that we must all, you just hold it in, and people are literally melting down. They are melting down in front of your eyes. And so we've been very deliberate in our conversation to say, if you need help, here is the number. And also having our managers and supervisors encouraging people, hey, why don't you talk? You need childcare. You need to talk to someone about your sick mom. You're really scared. You're afraid to go out. You're afraid for your kids. Why don't we call EAP? Why don't you call EAP? It's completely confidential. That is not the way most of us were raised. Most of us were raised is that you hold it in, you suck it up, you deal with it. And I think that is part of the trauma that those of us who have been born and raised, I'm 4 or 5 more than that generations here in the United States as slaves, you had to just endure it. You just had to suck it up. And we want to break that cycle. We are intent on breaking that cycle and creating a healthy environment for everyone. So I would encourage Black women in particular, when you're with your sister friends, to take that veil off and have a place and say, I'm scared, to say I'm exhausted, to say whatever it is you need to say, that you don't always have to wear that superficial face that all of us wear when we go into our work world and how people see us. You don't have to be strong all the time. And please, when someone says you're a strong Black woman, I correct them all the time. I tell them, don't give me that label. I don't see that as a badge of honor.
More of a burden.
I'm going to leave that there. Now, Dr. Altman, you got the floor.
Dr. Altman, yes. We'll follow you. Dr. Altman, you got the floor.
I just want to compliment Tony for a second. If you can give me a second to do that, Tony, would that be okay?
Hey, you got it. You got it.
Well, listen, I think Leandria was just talking about breaking the cycle. Okay. And I have a patient who is Black, and he said to me just a few weeks ago, when I recommended therapy, which he so desperately would benefit from. And he said to me, Dr. Altman, let me tell you a little secret. Black people don't get therapy. Right. And it's not the first time I've heard that.
Right.
And I don't know if you all noticed, but Tony just told the world that he got therapy. And that was a little bit of vulnerability and a little bit of courage on Tony's part. And that means something. That matters, because that's how you break the cycle. Leandria was just talking about people talking to each other about this kind of thing. And Tony saying that, I think is more meaningful than people might realize. And I think that somehow, like, therapist is like a dirty word, Joanne. Like, we can't say the word therapist. People are like, oh, that means I'm crazy. That means I'm weak, you know? And maybe we need to come up with a new word, maybe a coach. People don't mind having coaches. You're really cool if you have a coach, and maybe a mind coach, okay? Because there's not a soul alive that couldn't benefit from having a coach to help them about how they cope with the world around them and so on. Like, the only crazy is thinking that you couldn't benefit from that.
Right. Just don't call me Friday at 3:30. I'm with my coach.
Right.
So we're gonna watch another clip. and I think kind of spoke to some number of things Leandra was mentioned to. So could we put that clip up?
Of medical procedures, from the most simple to the most complex, Blacks and other minorities receive poorer quality care and less intensive care. We were not addressing issues of access. The question was, given access to care, is there a difference in the quality of care received? And we found absolutely there was a striking difference. We did not believe, the Institute of Medicine Committee did not believe, I do not now believe that the American physicians wake up in the morning and say, how am I going to get my minority patients today? I truly think that most medical doctors go to work and other healthcare providers and try to do their best for their patients. If that's true, then there's a conundrum here. How is it possible with people with good intentions seeking to do their best can nonetheless, at the aggregate level, create a pattern of care that is so discriminatory? Our answer was implicit bias. It's also called unconscious or unthinking discrimination. And when the IOM concluded that that was a contributor in 2003, there was a lot of circumstantial evidence. Today, the evidence is even stronger than it was then, that implicit bias exists among physicians and other healthcare providers, and that implicit bias affects the quality of care they provide to minority patients.
So I'm going to ask a question. I'm going to start with you, Dr. Baptiste. Medical mistrust among communities of color have led to often complicated views of how to protect ourselves and other vulnerable populations, especially during the pandemic. What approaches have been taken to reassure and to educate these communities about the benefit of being vaccinated? And furthermore, what do you think we should do, utilize this moment to rebuild trust amongst communities of color as we go through this pandemic and we discuss the need to take the vaccine?
Well, I think people are for many reasons, people do not trust the medical system. African American, there is a whole, you are played, there is the Tuskegee study, there is the history of Henrietta Lacks, and so on, and so sterilization. And so people believe that in general, if it's a good thing, it's not for them, it's for the white people. And there is all type of theory going on, saying that the vaccine, they give the white people one type of vaccine and the Black people a different type of vaccine. A lot of going in the internet. Some people say that they will become paralyzed. It goes on and on and on and on. But I think this is based on mistrust. And the mistrust is has to do since 400 years, and it hasn't gotten better. So I think in order for us to address it, we need to be talking to the community, right, to figure out what they are thinking and get some trusted leader in the community work with them. Another issue that I learned on vaccine is religion. So some people refuse to take it because, quote unquote, it was based on embryos. So there is all type of theory. So we need to know about them and dismantle them. And once a patient comes to me and asks me if they want to take the vaccine, I will try to investigate what are they thinking. So, and according to what they tell me, that's how I will tailor my answer. And so that's all we can do. I think the other part about that is accessibility. Right now, it's not necessarily accessible to everybody, and people have to go online and have to be able to do an appointment in the internet. Not everybody have access to internet, or not everybody have a cell phone. So we have to find out a better way to reach out to people, educate them, have a conversation with them. Then we can decide what how to address it.
Thank you. So Dr. Altman, going back just to, I don't want to say the theme, but the truism of disparities, right? Part of what Dr. Baptiste was speaking to also speaks to the fact that there are grave disparities in which she eloquently stated that have occurred for over 400 years in this country and still persists on a daily basis. How and why, how do we address the disparities, right? And not only the medical system, but how do we look at those disparities in the medical system to help us guide how we can make a better nation as a whole?
Well, that's kind of a heavy question, Tony. So what I would say is, first of all, racism is bad for your health. That's a true fact. We know this. We've got clear evidence. And we were talking earlier about maternal mortality. Sexism is bad for your health too. And when you're a Black woman, you have to deal with both. And I think coming back to something what Dr. Jean-Baptiste was just talking about, and you were talking about, Tony, trust, trust, trust. Yeah. It turns out that the medical establishment and people of color in this country have a big trust problem. Neither of them trusts each other. Okay, you were just talking about how Black people don't trust the medical establishment, and they have only about 100 reasons why not to. Okay, but we also know because of implicit bias. Okay, you're Joanne Bell? Oh, I wasn't expecting. I mean, oh, hello, Joanne Bell. There's like this implicit bias where when you tell me that you have pain, I don't believe you. Or you're saying you're having chest pain. Oh, it must be anxiety. It couldn't be your heart, right? And we've got so much data that shows white people and Black people saying the exact same words, and medical students and doctors having completely different reactions for no other reason than the color of their skin. And this is clear as day. And so there's a trust problem in both directions. And what I think we need to really do, especially related to this vaccine, is we need to do some listening. When I say we, I mean the medical establishment. We need to stop talking and do some listening, because the typical reaction of the medical establishment with vaccine hesitancy is, we're so smart, we know what's right for you, do what we say.
That's right.
And that doesn't engender trust. Yeah. It basically causes people to trust less, not more. And we need to do some listening. The other thing I wanted to mention, Dr. Jean-Baptiste was talking about access. You know, there are a lot of Black people who don't want to get vaccinated for a variety of reasons. But what people are forgetting is that there are a lot of Black people who want to get vaccinated and can't find out how to do it. Right? And so right now, I don't know if you all remember, like 20 years ago when the Toyota Prius got introduced, everybody wanted a Prius and you couldn't even get them. The way they produced this car is they only produced a certain amount of them. So to get a Prius, you had to get like on a 1 to 2 year waiting list. And that's what made like there was such a buzz. And what's happening now is everyone wants to get vaccinated. And there's this whole buzz about how everyone's staying up late at night, refreshing their computer, trying to get a vaccine, right? It's a great strategy to create this whole buzz. But what you need is a whole bunch of people who want it, and then a whole bunch of people who have gotten it and go around bragging, I got my vaccine, I'm so excited, right? And we need to do a better job of getting into communities of color and vaccinating people so that we can create that buzz of people being role models and saying, I got vaccinated and I'm fine and I'm so relieved that I got that vaccine.
You know, we're talking about something that's critically important to all of us. And we only have so much more time. So I want to actually, could we play the video? I want to play another video. I want to continue this conversation on vaccinations.
There is real, evidence, from history where there's been concerns about, experimentation. There is a history and there are plausible, it's plausible information that supports that. There's also been negative experiences that people have had in terms of healthcare. I think it would be irresponsible to just demonize the Black community for having these queries.
Hesitancy isn't rooted in that you're just simply being difficult.
For Dr. Vanessa Appiah, who's a vaccinator, she's on the front line of taking on the task of rebuilding trust within diverse communities.
There's a mistrust of the societal structures that we have, and really thinking, am I seen, am I recognized, am I valued, and will I be advocated for? We are just there to say things have changed, but we really appreciate and recognize what has happened before.
So Joanne, one of the things that, let's just, we're children of the 80s and 90s. I am a unapologetic hip hop head. And one of the things about hip hop that was beautiful of it, particularly Wu-Tang, and you loved Wu-Tang, partly why you love Wu-Tang, because they had a street team. And you would see wherever you went, right? It was very clear. And I guess the statute of limitations up, but I was a kid who went to Ringe and Latin, and I was sneaking to concerts at Harvard and BU, and I would just get these hip hop concerts. And it was really clear before I even got to the concert, I knew who was going to be playing that night. It was clear because their street teams let you know the flyers are up, the stickers are on poles. What do we think when we think about the vaccine? How do we employ school systems, municipal, offices? How do we create a campaign where we just first of all, have the conversation, see where folks are, but how do we get folks around the table, considering both what Dr. Altman said and what Dr. Baptiste said is that, and what we all know, that there's an aversion towards having a relationship with an institution that you deem to be predatory and oppressive to you. How do we re-engage community where they are to start thinking about not only this vaccine, but healthcare differently?
Well, I'm old school. I love hip hop too.
Okay.
But I think we got to go back to the old school days of knocking on doors.
Right.
Don't worry about going to the schools, go to the homes, go talk to the people, get back in the community and start talking and ask the question, what makes them comfortable? People know what they need. You don't have to try to figure it out. And the school systems, I support them because my children are in them. I actually went through school as well. So it's not a process. It's not a system that's not working. It's let's change the scope of how it works. Go to the people. When we talk about getting into the community to talk to them about the vaccines or even medical information, go talk to the people and the people will come. Schools, at this point, what I hear parents saying, particularly because of the role that I'm in at the mental health clinic, they're just trying to get their children back in school. They don't have time to be hearing about nothing because the parents have their own stressors and challenges that are going on. And they're trying to figure out, how do I balance my life and have to take care of my children? So that conversation is not taking place in that arena. But in your neighborhoods right now, because we're still in the quarantining, we're still doing the social distancing, you can talk right in the community. My neighbors, from the time I step outside my house, all of a sudden it's therapy sessions on the street, on the corner. You can't run from it because people want to talk. They want to tell you what's going on and they have something to say. And I think if we start going back to the old school of knocking on doors, go and talk to them first and give them that space where they can build that trust to want to come into that institution and have that conversation. That's one side of the house. The other side is sitting down with the educators. Talk to the teachers. A lot of teachers are parenting children right now. They're referees, they're doctors, they're nurses, they're the therapists. They're watching all types of things that are going on. And this concern about the vaccines, I'm hearing teachers, and I know we're talking about the community, but teachers are in the community and teachers are scared. Teachers are trying to figure it out. And so in this particular case, you've got to separate the two for just a moment, have the conversation, give them the education that they need, then bring everybody together. There's got to be that Pied Piper, that street team that you're talking about. It's us, the parents. We're part of that system where we need to come in and say, what do we know? Because we know what's best for our house. And we don't want to have things imposed on us because we've dealt with enough already. Now it's like, let's engage in conversation. And this is no different than relationship building. You don't just get trust overnight. It takes time. It's a process. And there's been that schism. There's been that break in communication. And social media has not helped that. I'm sorry to just kind of shift it real quick. But
no, I want to ask you a question as you're there.
Yes,
So
yes.
what we saw yesterday, we saw two things yesterday, and I'm sure that maybe we saw them, we've heard of them prior, but we saw two entities that play a big role, if not necessarily in our country and our psyche, both the NBA and also our U.S. military service, armed members. So in a CNN report by Ellie Kaufman and Oren Lieberman, the authors describe a division amongst U.S. military service members, with 1/3 of those eligible to receive the vaccine have stated emphatically, as of yesterday, that they are not interested in taking the vaccine. So we're talking about our military, right? And they're pretty frontline to me, right?
Sure.
So how do we reimagine even our folks in the military? We're not even talking about, the NBA. Also, a number of the stars have come out, and said, essentially said, look, we're not going to be the billboard for you once again. So putting on your community hat, and obviously the knocking on doors, we want to do that in terms of, but how do we incorporate those individuals who will be comprised of our street team? The grandmas, the folks own the bodega, the clergy, the doctors, the healthcare specialists. And so I want you to help us think about that. And then Leandra, maybe you can come in and kind of help us build on that as well. So I want to put that to you, Joanne, to kind of think about some of those players. Who are the we?
So the we, it starts with us right here tonight. This is the we. We take this conversation to the next level. That is, take it out. We came together tonight. Let's take it out and have those conversations in the communities where we are. The military is its own system. It's a beast by itself. So that in itself requires a whole different type of finessing. And that's a different type of relationship, because soldiers, and we've dealt with those as well, it's a different mindset. And so it doesn't mean that they're separate from us, but it takes a soldier to be able to speak to a soldier. It takes a parent to speak to another parent. It takes a child to speak to a child. You've got to speak to where a person is so that folks can be on the same level playing field. Oftentimes, it depends who the messenger is that causes people not to receive the message. Even if the message is the same, it's accurate, it's precise, and it's what's needed. But what happens is if the person looks at the messenger as someone that they can't trust, it doesn't make a difference. So we have to come to that level. So that community of people is us. We know the information, and it's time for us to go talk, have that talk. It's almost like having a big group therapy. We're going to take a big group hug and let's have a conversation. Let's go back to having town hall meetings. Let's go back to having church meetings. Bring all the engaging parties that are within a system in a city. We're not just talking about parents. You need to get the firemen, the policemen. You got to get everybody in a room and start having conversation to take away titles and sit down and start talking about the real deal, because people are steady dying. That's a real reality. And these traumas are impacting folk if we're not talking about it. And I believe Dr. Altman was right when he gave you a shout out about being bold about getting therapy. There's nothing wrong with getting therapy. We're all getting therapy every day. If you get advice from anybody, that is a form of therapy. Now, if we want to get clinical, that's a different discussion. But my bottom line is that it's okay to come and talk to people and let them know, especially now, facing this fear of the vaccine, whether you take it or not, which one is worse? People are trying to figure that out. They become their own doctors. They become experts on their own right because they don't know which way to go anymore. Bottom line, Tony, people are fearful to die. Whether it's the vaccine that's going to get you there faster, whether it's COVID, a heart attack, folks are fearful. And there is true fear that is prevalent. And that fear is causing a lot of people to make decisions, whether it's rash, whether it's delayed, but sometimes it's that pressure. So I'm not trying to get into that therapist mode, but we have to deal with this issue. And I think, again, it starts from.
I think that's brilliant. I don't have the money for the co-payment tonight anyway, but. But Leandra, as Joanne was talking, one of the things that have really struck me, what she was speaking about, and I want you to kind of help pivot us a little bit, is that in terms of we are in this space, right, where we're dealing with a lot of trauma, right? And in some cases, unfortunately, we're trauma bonding, right? We're putting ourselves in spaces where we're like, okay, my trauma is worse than your trauma, right? I lost 6 family members, you lost 7, right? You kind of get into these spaces, right? But how do we utilize this moment to make it a success? How do we find the beauty in the struggle of this particular moment? This moment being the pandemic or whatever you deem to call it. But how do we utilize this moment to bring back community, to reinvigorate, our healthcare system and how we view our, our healthcare system. How do we reimagine not only our school systems, but the ways in which we communicate with our school systems, from parent to teacher, school to pupil, right? Community member and activist to the school. How do we leverage this opportunity for some beautiful things down the line?
Wow, you're talking about giving me a big question. This is a big question, and I've been I see Dr. Altman is smiling over there. And as Joanne and Dr. Altman and Dr. Baptiste were talking, I just, I'm always trying to figure out systems and ways of solving problems. And it occurred to me, maybe there's already some group that has come together to actually train almost healthcare ambassadors. You don't have to be a doctor. We could train them. We could teach them, we train them. Here's what the vaccine is. This is, people have questions. We can redirect them. But I see an army of folks and not just doctors. It's me talking to my aunt, talking to my girlfriend, talking to the people in the grocery store. We have so many people that are unemployed right now. We have billions of dollars that are getting ready to come down the pipeline from the Biden administration. My suggestion would be to get some kind of consortium of folks together and say, we want to send these boots on the ground, because without these folks out here having these kind of personal one-to-one conversations, we're not going to make enough progress in our communities that are disproportionately impacted. So we want people from our communities talking to people in our communities. And that is how it's the only way I can think of, and no disrespect to the, to folks with degrees and other things, but, as we know, Dr. Altman, if you told me something, I'd probably just shake my head and kind of, I'm just going, yes, you to death. But if Tony comes and tells me something, or Joanne comes and tells me something, if Dr. Baptiste can talk in my native language and really can explain to me, what is happening, and can answer the question about how come they can suddenly come up with this vaccine, for instance, for COVID, but we're still looking for a vaccine for HIV. There's all kinds of questions going on. How come there's a vaccine in 8 or 9 months and for this and this, but we've been waiting 20, 30 years for this other thing? So that's part of like the whole conspiracy theory. Like you gotta be able to, pivot and answer all these kinds of tricky questions. So I think Tony and Joanne have heard me say before, nobody's coming for us. We have to come for ourselves. I think it's a loose consortium of organization that stands up a team that is really going to take this thing to the streets. So we can have people from the churches, we can have professionals that coach us, but really get down to the nitty gritty and then hit the streets. And that doesn't mean necessarily door to door, but it might be smaller pods, Zoom calls. There's learning hubs, there's churches, there's, grocery stores, just willing to have these conversations. It has to be done.
Tony, can I add to that?
Yes.
I want to talk about the Tony Clark Street team.
There's a Tony Clark Street team that he didn't tell me about?
There is now.
Yeah.
So, I volunteer.
Okay.
Me too.
We're going to call everybody coaches. We're going to call them coaches.
I'm a glass half full kind of guy. So when you tell me a third of the military and a third of the NBA and maybe a third of the Black community in Cambridge doesn't want to get vaccinated, I say, well, I think what you're telling me is that 2/3 do. So that's great news. And I think what we need to do in parallel with what Leandria is talking about at the exact same time, we got to get these 2/3 vaccinated. Because when they get vaccinated, they're going to tell everybody else, we've got our ambassadors without even trying, because they're going to start telling everyone else, I got vaccinated. And it's going to create a buzz. And we got to do all the things that Leandria was just talking about. But at the same time, we've got to get these 2/3 of people vaccinated. So I'm going to promise you 2 things. Number one, if you get a group of people, I don't care if it's Brockton or Stoughton or Cambridge or wherever, that want to get vaccinated and they're eligible by the state, phases, whatever phases, they're eligible to get vaccinated. and you can get a bunch of them in a big room, or we can help find a big room. I will bring my team. We'll bring 100 vaccines and we'll vaccinate 100 people in an hour. Boom, safely, efficiently. We'll answer all their questions. We'll have fun. We'll give them some snacks. No snacks. They got to stay with their mask on. My bad about the snacks. But I will do that. If you can get a big group together that wants to get vaccinated, we'll make a big party out of it. Okay, we'll give them some snacks to take home.
Exactly, snacks to go.
We'll make that happen by mid next week. We'll have the names to you.
I love it. Let's find this big space, get everyone there, and we'll make it happen. The other thing I'll promise to do is if you want to get a group together, whether Zoom or in person in a socially distant way, even outside, if it's a reasonable day and people can wear their jackets, I'm happy to train ambassadors or answer people's questions or get there. Okay, because we have got to get these 2/3 who want the vaccine. Instead of fighting so hard for the 1/3, let's get these, in addition to.
Can I push on you a little bit? Can I push on you a little bit? And
Please do.
I thank you for all of those things. Actually,
thank you.
This is both to Dr. Altman and Dr. Baptiste. I think there is a narrative, right, that Black folks are anti-vaxxers, right? And in terms of, there are two camps, right? But I think that in terms of, I want to just be conscientious of, I know that prior to this conversation, I was talking to a family member. I'll let them be anonymous because they're on this call and they're eligible, right? And they felt like when they got on the call, they just couldn't get through the system. We're dealing with a subgroup of folks who have had an aversion towards technology for years. And they feel like, once again, I've been let down by, in a lot of cases, my country, right? I've been given, if you look at what happened in Florida, and we saw in terms of, I think it's a Rancho something community where the governor essentially said, had 3,000 vaccines, and they overwhelmingly went to white folks, particularly white folks of privilege, right? And this is a community that has a large swath of Black folks. So much so it's become a national story. Like, hold up, we also have Black folks who fit this criteria, and they felt like, look, and then, and so there was like this proverbial, moving of the dial when it became to the Black folks, like, well, you know what, you had to have this and you had to have that, very much in some ways feeling like, Jim Crow, and you need that, you need to pass the voter test, right? How many coins are in this jar, right? And so I think there needs to be another conversation that is very clear. Like, look, Black folk aren't anti-vaxxers. They're essentially saying, look, I've had an adverse relationship with the medical field for years, and I don't trust that you're all of a sudden just going to put me at the top of the line and treat me, like folks who are also my counterparts who may be white in some cases, right? And so I just want to kind of put that out there. My question, I wanted to go back to you, Dr. Baptiste, because of your work in Cambridge.
Yes.
And Cambridge very intimately, and the fact that Cambridge, as you know, has a variance of different communities, right? And different, and quite frankly, I think we're amongst family, we can say Cambridge needs to do a better job of walking its talk, right? We say we're a community that believes in racial equity. We have our ethos of being together. But we look at our school districts, and we see great disparities in our school numbers. We see in terms of the rates of our black and brown residents are dying a lot younger than their white counterparts. We're seeing more, childhood obesity rates, based on race that are grossly different. Asthma rates, you can name it, right? In terms of, and so I'm curious from your perspective, how does Cambridge as a community, considering how different Cambridge is in different swaths of the city, how does Cambridge put out a campaign around not only vaccination, but just the importance of using the vaccine as an option? So how does Cambridge market this moment?
Well, I'll go back to what people have said before. I think outreach is key. I remember years ago, we used to rely a lot on outreach worker. And we also have a community of volunteers. So those people are people you train, and they go train the community. Because what happened is I myself used to do group visit. Why I did group visit? Because I believe if a neighbor tell a patient something, that has more value if I say it myself. So when I used to go group visit, I used to have a bunch of diabetes patients. The one who are doing well or the one who are teaching the other one. And we had good results with that. So this peer-to-peer education is really key. We need to train outreach workers, have them accompany the patient and help them out. Not everybody can use their cell phone. Not everybody has a cell phone, but they know they have somebody they can turn to and that person can help them. I can tell you most of the time people run out of health insurance. It's not because they are not eligible, because they don't open their mail. So what we need to have people in the community helping out those who cannot.
You know, you said something, and our brother James Pierre put something in the Q&A. I think it's really important. I want to stay with you. He said hospitals have trained interpreters for patients who don't speak English. I think it would be a great idea to have these ambassadors for Black people. Obviously, they speak English, but you have to kind of speak to them in a very different way around some of their aversions towards medicine. Can you speak to that a little bit in terms of how do we utilize the ambassadors, as other folks have mentioned? Everyone answer.
I am a big believer in if you do education and you talk people in their term, then they can understand, then they can adhere to treatment. If I come and I tell you your A1C is 7, then oh yeah, okay. But I have no idea what A1C is, which is a blood test for to control would tell me what your blood sugar has been over for the past 3 months. But if I explain to you, this is what I want you to do to improve your blood sugar, and this is the way we measure your blood sugar, then I understand what you're telling me. I am more likely to do it. So in the medical field, I think we always speak jargon to the patient, and that's not helping either. We need to speak the language that person speak. If that person is doing like sport, you use the sport language. Whatever they do, you need to use imageries so people understand what you're telling them, so they are more likely to follow your advice. You tell people
finish, Doc.
Yeah, you tell people to take vaccine. What is a vaccine? So you need to explain to them what is your system immunity system is, and what is the vaccine is going to do to you. Then I understand why I need to take it.
Awesome. We're gonna 90 seconds. If Joanne, you can talk about ambassadors as well. Leandra and Dr. Altman, if you guys each can talk about that for 90 seconds. I'm gonna ask one more question, maybe a couple more questions in the chat, and then I'm going to open it up for you guys to kind of have your last comments. So Joanne.
Sure. So these ambassadors, I love what Dr. Baptiste just said there. You have to come into people's language. Even from a therapist standpoint, I can't be telling people all of the clinical ease and they're looking at me like, so what is my diagnosis? What does that mean? How is that impacting me? We have to speak in that language. Just like you won't come to a child speaking in a collegiate language, speak to people where they are. Don't speak down to them, speak with them. Talk to them, build that relationship, build that currency of trust. And that ambassador is going to be someone that's already overcome, whether they got the vaccine or not. If they're trained properly and they're trained with empathy, we have to go back to love. We have to go back to caring, so that that person that's going out there is not coming out there being, or coming with all this head knowledge, but coming with heart knowledge and saying, you know what, let's talk about you. Let's check in with you, find out where people are. And it's important, I think any ambassador, someone that's going to be speaking up is someone that's speaking from that community. I think Leandra was spot on. People of color, Black people in particular, they want to hear from their own. And it's like that, I think, in any culture, that's where that trust starts in, is bring someone that looks like me, looks like you, that can come talk to me and not come at me. So I would say that ambassador needs to be someone, no matter what race they represent, go speak to your own, and your own will hear you, even if they don't receive. everything that you're saying.
I want to continue with this line of questioning. I want to go actually jump to you, Dr. Altman, and come back to Leandra. For over 30 years, right? For, at least for 30 years, we have been affected more than that with AIDS and sickle cell and other types of diseases, and there's been no cure, right? And so how do you kind of dispatch an ambassador out there who feels like, look, you're talking to me about this vaccine. You know what? I got a younger brother who's dealing with sickle cell.
Yeah.
You just turn this around that quickly. I'm not into that. So how do we get that person to kind of sign up for this type of work?
Yeah, so two thoughts on this, Tony. The first is, I don't think we've helped you very much in this conversation because we keep on talking about community ambassadors, which is a fancy way of saying the Tony Clark Street Team. You came up with the idea. We're just making it sound good.
Right.
Okay. So, but the idea is great. And it is human nature that you're going to trust and hear things better from people who look like you and come from your community. That's how it's always been. And so it's a great idea and something that we should work on for sure. Regarding your question about HIV, I'm going to give you a little bit of a cynical answer. We had a cocaine and crack epidemic in the 80s that was predominantly affecting the Black community, and not much was done about it except for putting people in prison. And in the last 10 years, we've had an opioid epidemic in the United States that has affected a whole lot of white people. And all of a sudden, millions and millions of dollars need to be put forth into treatment. And let's not put people in prison. Let's treat people, because this is an addiction, which of course is correct. And we agree with that, but it was correct in the 80s too, except somehow we had a completely different response. And, HIV is a disease that at the start predominantly affected gay people. And there was a lot of bias towards gay people. And so I think that this pandemic, everybody dropped everything in the scientific community to try and figure this out. And that kind of level of commitment has not been in place for things like HIV or sickle cell.
You raised something. I wanted Leandra, you mentioned something around crack and the opioid. And one of the things in which the marketing we've seen that the opioid was a crisis, crack was a war, right? We're going to wage war on Black bodies, pretty much, right? And we are going to try to find refuge for white bodies because it's a crisis, right? And so keeping in mind language and how semantics works, how do we roll out a plan that looks at the fact that in terms of we don't want to, once again, or I don't want to, I don't think any of us do, demonize one group with a set of language, but humanize another. And so how do we utilize this moment to utilize language that's going to bring us together?
So I'm hoping that he's not asking me that big. That's like a.
You can start it and we'll
I noticed that
at it.
I noticed that everybody looked at,
Yeah, but I mean, it's in our theme, right? Medical racism, but it's also in terms of language is very pervasive and predatory, right? In terms of when we think about, crack, it was like, look, we're not only going to address crack from a systemic issue, but we're going to create a political infrastructure that does what? That breaks up families, right? That, that disrupts generations, right? Whereas when we see this opioid matter, we see municipalities, even the one in which, we work and love. And, I'm a Cambridge kid, but I have seen the city of Cambridge open itself up, open its doors, and essentially say, let's have a conversation about opioids, right? And they've done it in a way in which they have gotten Black and brown folks to say, look, whose families, like mine, many years ago, hemorrhaged from crack, right? I'm not gonna, thank God that wasn't my mother or anything like that, but you have aunts and you have uncles, you have cousins, at least I did, who have been inflicted, right? I was blessed not to have a parent So it wasn't hitting me intimately, but it does, and it did. But it seems to be this level of humanity when those things hit, young people whose parents are on opioids, right? Or who are battling it, right? And so I think there needs to be some really strong conversations around language and how we create language that is not exclusionary, but we create language that is more, provides people with a space to feel like, okay, they're talking to me as well. So it wasn't designed to, throw a wrench in anyone, but I do think I want to just help us think about how do we create language where we bring people in to the space.
Language is critically important, Tony. You're absolutely right. It makes so much of a difference.
Right.
Especially when we're talking about trust.
Definitely. Leandra?
Dr. Altman, I'm just thinking that we'd have to be very thoughtful in developing this curriculum for the Tony Clark Street team. And before we let them loose on the community, we'd have to have some of these painful conversations about why Black and brown people were locked up. And then when white folks got sick, they call it, it's a crisis and they're sick and everybody, it's a kumbaya moment. Because those are conversations that they're going to have when they go out in the community. If they come to some people that are woke, right? They're going to be like, don't come here with that because you're too young. You don't know what else happened before last time. You don't know what happened with AIDS. You don't know about sickle cell. They don't come for us. They're not interested in us. They're up to something. So I'd want to put that street team out there fully trained and then they'd have to have a backup or a coach because they're not going to have an answer for everything. But I think, when Joanne was talking about how we approach them and we approach people where they are, Dr. Baptiste, we're approaching them with love and empathy because we care for them. And we're not going to leave them. It's the only way this can work, but it has to be some kind of consortium. I mean, I volunteer Victory. We're happy to write grants or do other stuff. We were made for this moment. We are here for our community. This is why we started. We're 20 years old. We're Black led, women led. We give the guys a little bit of credit, but we've got a really diverse group up here. But I make that commitment that if there's a group that really wants to really dig in, seriously dig in with excellence, then that is something that we can do. Dr. Altman, I heard you say you're coming with that vaccine. I've got it on tape now. I've got 4 witnesses. Look at them.
But to that point, Leandra, I want to challenge all of us. I think, and I'm not going to be the bearer of the vaccine. I think before we get to the vaccine, we would also benefit from 100 doses of therapy, right? Because there's a lot of trauma, right? There's a lot of just, deep-rooted trauma, and folks are traumatized, and they're dealing with deep-seated intergenerational trauma that has to be in some ways reprogrammed. And that in terms of, obviously, I don't believe this to be true. It can't be a one-off, right? It has to be something where we begin to have that conversation that's really rooted in what? How do we heal? How do we make sure we don't pass those things on, to the next generation? I often tell this story. I was having dinner, and the boss lady said, "You know what? You're not going to wait for us?" And I was like, "What do you mean?" And I had to reprogram myself that I wasn't dealing with myself, because in terms of I had made the decision that I was by myself and I was operating in my own. I was operating my own trauma. That like, look, what do you mean I have to eat with you? And she was like, "Oh no, our family's going to do this. These are the norms and the practices, and this is the pedagogy in which we're going to work as a family." And that helped shift my paradigm of how I saw family, how I see family, and how I govern my relationships. And so I think that in terms of we have to spend a little bit of time of, having another conversation around why do we have these, aversions toward the vaccine? Why do we, feel like, I have this deep-seated relationship, not only with the police department, but with my school, right? We have in some communities where folks have more trust in the police, Black folk, than their schools. And so there's a number of situations that we need to address and need to illuminate. I want to stop there, and I want to give everybody, I'm going to go around, I'm going to start with Joanne and give folks 90 seconds to just leave us with some gems and some points of wisdom that we can take moving forward. And I want to thank everyone for coming out tonight. This has been a great conversation. This is not the end of it. As we noted, Dr. Altman will be working with us, and we're going to call it the MBK Street Team, because as I see on this call tonight, I'm welcome. I'm here with my brothers and sisters in arms, my brother's keeper and my sister's keeper. I have to do a better job of illuminating both of our works, and so I want to just thank the brothers from my brother's keeper. Thank Calvin Lindsay and Danielle Jones of 22 City View who have put this together. And I want to thank all four of you for being a part of this conversation, because you're not only pushing us to think bigger, you're challenging a city to be curious. And I think we have not allowed ourselves to be curious enough. Far too often, we are marred in compliance and we are not allowed to be curious. So I want us to be more of a curious community and not so marred with compliance. So I'm going to start with you, Joanne. Can you give us some parting thoughts?
Number one, mental health. We got to check that first, right? It's the whole concept of putting that oxygen mask on, taking care of you first, and then you can take care of others. We got to pay attention to each other. We got to listen to each other. We got to support one another. We got to pray for one another, if that's where your faith is. But in this time, just in what we're talking about tonight, at the end of the day, because this is real, it's a real, these are real issues. These are real challenges that people are having. Have that open dialogue. Check in on your families. Take it back home. Check after this conversation today. Talk to someone at home and see where they are. I'm big into checking your own temperature, because COVID has taught people to check in temperatures for other reasons, but check the temperature of where your loved ones are at. Because all in all, it's the family that makes up that community, that makes up our society, and the family has to be healthy. They have to be whole. And let's not judge each other if we are not going to take that vaccine. That's not the bigger issue, because at the end of the day, whether you take it or not, if that person still has not checked in and they don't have that psyche that's right there in place, you're not going to be able to be stable. And I think people need to do that wellness check, mind, body, soul, spirit. I think that's important. And these conversations, let's not be afraid to have it. Let's have those difficult conversations and walk away still loving each other, not hating each other, not having all these, because we know, like Dr. Altman said, that there's going to be biases out there. We understand that. And some of us have been predisposed to having them because of different images that we've seen, different traumas that have happened that have caused that to take place. But ultimately, let's sit down, let's listen to each other, let's learn from one another so we can help each other heal.
Dr. Altman?
Joanne Bell taught me that mental health is mental wealth. So Joanne, I ask you this question. If you could wave your magic wand and all these people, okay, in the community say, yes, I'm going to go get myself some therapy.
Yes.
Okay. I want some of that mental wealth.
Yes.
And I want to get a therapist that looks like me, that comes from my community. Well, guess what? We're not going to have enough people for them.
Okay.
And I'm not saying that we should stop them. What I'm saying is that the MBK street team, not only are they the street team to talk about the vaccine, but they are future therapists and physicians.
Yes.
Right? So this has two purposes. There's a short-term goal and there's a long-term goal to create future mental health professionals and healthcare professionals, which we so desperately need.
Absolutely. And honestly, to your point,
John.
Dr. Altman, there's something I'd like to say to that point. Let's make these professions be okay in our communities. Let that be something they thrive for. I have a son, and I told him it's academics over athletics all day long. Show me your grades, then you can show me what you're going to do with them. And so I think it's the same thing. Have those conversations at home. People of color, talk to your children about profession. And those of you who don't know, go ask somebody. There's no shame in it. What do you do? And how can I become like that? Have those conversations so that people can know There are Black doctors out there and nurses, people in the in the medical profession, as they are therapists. And guess what? They're doing well, but they're here to help. And you'll find, I think one of the things I'm hearing you say is, how can I locate that? Where can I find that kind of help? There are websites out there that you can search for a therapist that looks like you. Therapy for Black girls is one that comes to mind. But Psychology Today, there's resources out there in which you can look for doctors and or therapists that are out there that look like you, that can help treat you if that's what you like.
And I would just say that in terms of, we want to make sure we get everyone in.
Yes.
When I found you have to shop, right? I found a therapist and it wasn't the right fit. I had my own anxieties around therapy. She was always late. And if you know me, I get a little overwhelmed when people are late. She didn't have a consistent day. I was like, am I your therapist? Are you mine? So it was one of those things you got to figure out what's the best fit for you. So shop around, right? Shop around.
Yes.
You have to.
I know folks who been very intentional, who are Black folks who don't look for Black therapists because they're like, you know what? I don't want to be talking to my auntie, right? In some cases. So you got to figure out what's best for you. Mm-hmm. I want to let you finish your thoughts, Dr. Altman, and then go to Leandra.
So just 10 more seconds. The last thing I want to say is that when we approach people, it's been said earlier, we approach people with love and listening. That's the approach.
Got it. Leandra?
The L's. With all the L's, we can go to Leandria.
Okay. Okay.
So, you guys have just kind of just said it so well. And I love that we have Dr. Baptiste at the end. What I want to make sure I tell folks is we're ready. Let's work. I love that we're going to pray together and we're going to, do all these other things. But at the end of the day, we've got to create an organization and let's get to work. Now, that's what I know how to do. Let's work. Let's not be a group of talkers and we talk about it and it's all talk and it's in the air. Let's get to work. Nobody's coming for us. We are who we've been waiting for. It's not.
I love it.
Feds.
Love it.
It's not going to be the city. This is it. This is the time. Let's not just be talking. I'm not big on doing a whole bunch of talking. Sorry, Joanne. I know you make me talk sometimes, but let's get to work. Let's use this time to affect our community and get the work done. Let's get it done. There's other people on the call that'll be listening. I'm hoping they can contact Tony and say, hey, we've got this. Hey, we can get food. We can do this. Everybody has a part to play. It's not one person's job. It's all of our jobs together to get this done. So that's what I wanted to say. Thank you, Tony.
I want to thank all of you. I want to especially thank Dr. Baptiste, who's going to help bring us home.
That's a big task. I don't think I have much to say. I agree with everybody. I think community is important. It's working with the community, for the community, with them, but not so helping out, meeting where they are. That's the most important. I also believe that working on the pipeline, as you suggested. So having a young, going to modeling for the young people. And as they go up, so they want to become professional. And there is also one thing I want to say. I think the system, the school system has so much social racism. Oh, yeah. And not enough help is given to the young Black people. Because they traditionally come from home where there is not a lot of support. Whereas in the Caucasian family, their mother went to college and they know the system, so they are able to give them the help that they need. So what happened with the young Black, they are left behind and they lose their self-esteem, and that's all, and they become lost in the system. So we as professionals need to think about that and see how we can support the community and those young people who are coming. That could be one way to work on the pipeline.
That's awesome. I just want to remind folks that this presentation will be aired on 22 City View on Monday, February 22nd at 3 p.m., at which time also the taping of this show will be available on the 22 City View YouTube page. It will also be re-aired on Wednesday, February 24th at 8 p.m., Friday, February 26th at 8 p.m., and on Saturday, February 27th at 3 p.m. And I think it's critically important when you get the YouTube video, if you have folks in the Cambridge area, to have them tune in, as this is a very important conversation, and hopefully it's not the only one occurring right now, which we know a number of organizations are having this discussion. And we're going to continue to do this work. And we're excited about this work. We're excited to be in community with these brilliant minds. And we look forward to future conversations. So thank you for coming out tonight. And good night.
Thank you.
The medical profession may be doing harm to patients and communities. Many years ago, as a first-year medical student, I took an oath, like thousands of physicians before me and thousands of physicians after me, that I would first do no harm to the patients and the communities that I serve. And since then, I have committed my career for taking care of patients in underserved communities, just like this one on the Near East Side of Columbus, Ohio. But over time, I've seen that the medical profession has broken that social contract with the communities that we serve because of racism and placism. Now, this is going to be best illustrated if I walk you through the lives of two of my dear friends. So first, let me tell you who they are. Many years ago, as a young, aspiring physician, new to practice, I started my career off in Connecticut, where I had the good fortune of meeting two wonderful women who would become lifelong friends and honestly like family. And it is through their lenses that I will walk you through the impact of racism and placism in medicine. So first, I want you to meet Wendy. Wendy's a Black woman. I met Wendy as a middle-aged mother, hardworking woman, working so hard to provide for her kids. Through my relationship with Wendy, I've learned so much about tenacity, grit, and honesty. I also want you to meet Sarah. Sarah's a white woman. I also met her as a middle-aged woman, a mother, hardworking, did so much to provide for her family as well. And through my friendship with Sarah, I've learned so much about allyship and loyalty. Now, when I met Wendy and Sarah, they lived about 6 miles apart in central Connecticut. Sarah in the wealthier suburbs outside of West Hartford, and Wendy in the inner city outside of East Hartford. Although they only lived 6 miles apart, their potential interactions with the healthcare system could not have been any more different because of racism and placism. So let's talk about what those mean and what those look like in medicine. Racism in medicine means that Wendy, as a Black woman, would be much less likely to have positive interactions with the healthcare system, much less likely to be taken seriously by doctors, and much less likely to have state-of-the-art healthcare wherever she lived. Because in medical school, we are taught that Black patients have a higher threshold for pain. If Wendy came to my office presenting with pain, as a Black woman, she would be significantly less likely to have that pain addressed. Similarly, if Wendy, as a Black woman, presented to the emergency department with crushing chest pain, she would be 50% less likely to receive any life-saving intervention for a heart attack. Now, in medicine and in nursing, we're often taught to discount and discredit the symptoms of Black women. So if Wendy, as a Black woman, went through her pregnancy, she would be 3 to 4 times as likely to die in that pregnancy or in the childbirth than Sarah would as a white woman. Similarly, if Wendy gave birth to a baby, she would be twice as likely to bury her baby before the age of 1 than Sarah would as a white woman. And if Wendy gave birth to a Black baby and that baby was taken care of by a white physician, that baby would have an increased risk of dying in that first year. Racism in medicine also means that although Wendy, as a Black woman, would be much less likely to be diagnosed with breast cancer or colon cancer, if she were diagnosed, she would be diagnosed with much more advanced disease, later stage disease, and have a 50% higher mortality than Sarah as a white woman. And so it's not really the phenotype of race, it's the structures of racism that would lead Wendy to toxic accumulation of stress that would lead her to earlier heart disease than Sarah. So racism is taking its toll in medicine. Now, the other issue is placism. And by placism, I mean the ignorance of a person's place, where they live, their zip code, on their health. We know that 80% of a person's health status is determined by social determinants of health, not their interaction with me as their doctor. The conditions where they live, work, play, school, housing, economic security, jobs, safety, violence. But chances are your doctor has looked at you and made a decision on how they will care for you based on your race, but they have never paid attention to your place or your zip code. So this shows up in significant health disparities in life expectancy. If you look at the state of Ohio, in green, you'll see the wealthier parts of the state. People have a life expectancy into their late 80s, almost into their 90s. Not too far from some of these same places in red, you see that people have a life expectancy in their 60s. So there can be a 29-year difference in your life expectancy based on where you live. Now, if we zoom in on where I am right now in Central Ohio, the life expectancy challenges are the same. You can see places that are not that far away have over 27 years of a difference in life expectancy between the poorer and the wealthier zip codes. Where I'm standing right now on the Near East side of Columbus, Ohio, a mile away in a wealthier suburb of Bexley, people are expected to live 18 years longer than the people in the community that I'm standing in. Chances are, no matter where you are in the United States, these same health disparities exist. These same problems based on your place exist. So back to Wendy and Sarah. When I met Wendy and Sarah, they lived about 6 miles apart. But that meant that Sarah was expected to live to the age of 84, and Wendy to the age of 68, a 16-year difference based on 6 miles. So you may wonder, what if we just moved Wendy over to where Sarah lived? Would that change? Unfortunately, because racism would follow her, Wendy's life expectancy would not change. It would be as if Wendy lived in the same place for her whole life. And that is because racism is the father of placism. Placism is the derivative of racism. Structural housing discrimination, redlining, and many other structural factors have led to the reasons why people in certain communities have lower life expectancies.